Good morning, everyone, and welcome to the Wisconsin Cancer Collaborative's Lung Cancer webinar. My name is Olivia Steitel, and I am an outreach specialist for the collaborative. We're really excited to have you on the call today. If you haven't already, please introduce yourself in the chat so we have an idea of who's joining us today. All right, so our webinar is going to be split up into 3 presentations, and then we'll have time for questions and discussion at the end. So first, we're going to dive deeper into the data and findings that were presented in the Lung Cancer in Wisconsin report. And then we're going to learn about how Advocate Aurora Health approaches their lung cancer screening program. And then finally, we're going to hear from the Wisconsin Indoor Air and Radon program, highlighting some of their resources and their statewide Radon Action Month activities. I'm excited to introduce our 4 great speakers this morning, who all represent different perspectives within the cancer space. So Lena Swander is a cancer epidemiologist at the Wisconsin DHS, Wisconsin Cancer Reporting System. And Lena will provide the data overview as one of the primary authors of this report. Then we have Megan McHugh, who is the manager of the lung cancer screening program at Advocate Health Midwest, and is also an oncology certified nurse. Megan has expertise in program development, patient advocacy, and multidisciplinary collaboration. And then joining us is Amanda Cook, who's the program manager, and Kim Dawson, who is the outreach specialist, both for the Wisconsin Department of Health Services Indoor Air and Radon program. They both bring extensive public health experience to their relatively new roles in the program and are excited to share what they've accomplished this January during Radon Action Month. The work that the Wisconsin Cancer Collaborative does with partners like all of you on this call today really is driven by the Wisconsin Cancer Plan 2020 to 2030. The plan outlines our state's cancer prevention and control goals, along with best practices and resources needed to take action to reduce the burden of cancer in our state. So the Lung Cancer in Wisconsin report that will be discussed today is both an outcome of the cancer plan and it mirrors its structure. So priorities from all chapters of the cancer plan are reflected in this report. In particular, Chapter 2, which focuses on risk reduction, is highlighted in the sections involving reducing exposure to commercial tobacco products and radon, which we know to be the 2 leading causes of lung cancer. Chapter 3 focuses on early detection and screening, which includes the screening guidelines and barriers discussed in the report. And finally, this report is really closely aligned with Chapter 7, as it was driven by data from and collaboration with the Wisconsin Cancer Reporting System. So by sourcing Wisconsin-specific cancer data sources, this report not only highlights available data for lung cancer outcomes, but also really identifies some data gaps within this cancer topic. All right, so I'm going to pass it over to Lena. So I'm going to stop sharing.
Right, live transition. Here we go. Okay. Hopefully everyone can see my slides. I'm going to go to presenter view. Is that showing the slides for everyone? So,
yes, looks good.
Seems impending. Great. Yeah, so good morning, everyone. Today I'm going to be highlighting some of the key data points from the Lung Cancer in Wisconsin report that was released a few weeks ago. You can find that on the Wisconsin Cancer Collaborative's website. So I hope everyone, if you haven't had a chance to check it out, please do. It was a really collaborative effort, and we're excited that it's finally out in the world. And so you heard Olivia mention that a lot of the data in Wisconsin for cancer incidence and mortality comes from something called the Wisconsin Cancer Reporting System, which is where I work as an epidemiologist. We were established in 1976 by Wisconsin statute, and we're basically mandated to collect cancer incidence or new case data for the entire state of Wisconsin on all of the residents. So we're housed in the Wisconsin Department of Health Services at the Division of Public Health, and you'll probably see our data, or acronym WCRS, sort of peppered throughout a lot of different cancer collaborative data briefs and the plan as well. So our data are used in public health surveillance and to support cancer prevention and control research. We always like to remind people that our cancer incidence data are dynamic and that we're constantly receiving information from hospitals across the state and cancer reporters. And currently, as of late last year, we have high quality incidence data for cases diagnosed between 1995 and 2022. The data featured in the report and that I'll be discussing today, however, focus mostly on 2010 to 2021. So 2022 was not included just because it wasn't frozen for use in the report. So just want folks to know that the next year is available, but we'll be focusing on up through 2021 in our data today. So for a lot of folks who are probably familiar with lung cancer, you might know that, you might know that it is a pretty impactful condition and disease. In fact, it claims more lives in Wisconsin than colon, breast, and prostate cancers combined. Some of the other big facts that we highlight in the report, so lung cancer is the second most common cancer for both men and women in the US. In Wisconsin, there are about 4,400 new cases of primary incident lung cancer each year. And so we end up losing about 2,590 lives, disease annually, deaths annually, people in our state. And notably, lung cancer accounts for 1 in 5 cancer deaths nationwide. I just want to take a second to highlight that there are actually 2 types of lung cancer, and they're named for how they appear microscopically. About 15 to 20% of cases are small cell lung cancer, and those are strongly associated with cigarette smoking. They're typically treated with chemotherapy. And then about the other 80% of lung cancer cases are non-small cell lung cancer, and this includes adenocarcinoma, large cell carcinoma, and squamous cell carcinoma. And these generally grow and spread more slowly than small cell lung cancer. The report and then the data that I'll be showing today, we group both of these types of cancer together and all the official statistics that we report out, including mortality statistics. Over the past decade, we have observed significant declines in Wisconsin lung cancer incidence rates. And so what you're seeing on the screen here, we have modeled regression lines over time from 2010 through 2021. And you can see that both for the US and Wisconsin, we're seeing declines. So US is in the teal color, and then Wisconsin incidence rates are in orange. And one thing that we point out in our report is that we've noticed that around 2018, the Wisconsin rate looks like it's declining slightly lower or at a slower pace than the US overall. And so this suggests that while progress is being made, there's still likely a lot of work that needs to be done in our state to accelerate some of the positive trends that we're seeing. We've also seen over the past decade a significant decline in mortality rates as well. And so similarly, what you're seeing here, instead of incidence rates now, we're looking at mortality though, for both the US and Wisconsin from 2010 forward. And you'll note that both the US and Wisconsin are declining at about the same pace since 2010 forward, which is great news. The report also examines some differences in different demographics in our state, and we took note of a couple notable disparities that have emerged. So men exhibit higher lung cancer rates than women, and especially in older age groups when the disease is most often diagnosed. So what we're seeing here on the screen in the orange are male rates and then female rates in blue, and different age groups at diagnosis. And so you'll notice that in years 60 plus, the differences between those bars tends to get a little bit larger, where the disparity is more prominent. Men are also more likely to be diagnosed with lung cancer at distant stages when it's harder to treat. This is something that we see nationally as well. And the reason for these observed differences in lung cancer incidence and outcomes is pretty complex. But the literature suggests that it is likely involving, a combination of environmental, biological, behavioral factors. We also know that historically men have had higher smoking rates. In the mid 20th century, smoking was heavily marketed to men, and this has led to long-term exposure and risk as they've aged. So although smoking rates have declined, older generations of men still carry a higher lifetime risk. And so what I have on the screen here, and this is also found in our report, these are percentages of total lung cancer cases at the stage that they were diagnosed. And you'll notice that for men, a slightly greater percentage of those total cases are diagnosed at a distant stage, so about 48% compared to women where it's about 43%. The report also took a look at some pretty stark racial and ethnic disparities that we see in our state. These are also things that we saw across the US as well. So non-Hispanic, American Indian, Alaska Native populations have the highest rates of lung and bronchus cancer in the last 5 years. And so what you're seeing here are incidence rates from 2017 to 2021, comparing the different racial and ethnic populations in our state. So in the teal, you'll see Wisconsin overall on the very far left there. That's kind of what we use as our benchmark when we're looking at disparities. And you'll see that all the way to the far right that non-Hispanic American Indian Alaska Native populations in Wisconsin have significantly higher incidence rates. So although the data aren't shown here exactly on this picture, we do have more information in the report about non-Hispanic American Indian Alaska Native populations also tend to have lowest survival rates as well from lung cancer, and they also tend to have higher proportions of cases diagnosed at later stages. And just want to take a moment to recognize that these disparities are incredibly complex, and we do know that it's a combination of factors, higher smoking rates, limited access to healthcare, environmental exposures, and socioeconomic barriers play a significant role in contributing to these disparities in these communities. And just wanted to mention that the disparity is quite large in Wisconsin, that for this population, it's nearly 2 times that of the Wisconsin overall rate. We also note in the report that non-Hispanic Black and non-Hispanic American Indian Alaska Native populations in Wisconsin have the highest rates of lung cancer mortality as well for the last 5 years of available data combined. And both are 1.5 times that of the Wisconsin overall rate. So similar graphic that we saw on the last slide, but now we're looking at mortality rates. Again, the Wisconsin overall rate is that teal to the far left. And you'll notice that for non-Hispanic Black and American Indian Alaska Natives, the burden is about 1.5 times that rate. So lung cancer incidence and mortality, we know that also varies by geography in our state. And that for the most part, what we were seeing is that counties that tended to have higher lung cancer incidence rates also tend to have higher mortality rates as well. It's a pattern that is seen across the US as well. And some of the geographic differences, again, are very, very complex. I know I'm going to show a map in a second, and I know when all of our brains tend to see maps that, you start to make assumptions about why something might be happening in a community. And I just want to remind people that um, these issues are very complex. So we do know that some of the geographic differences in lung cancer rates can be explained by variances in known risk factors like commercial tobacco use. So for example, rates of lung cancer and other higher tobacco associated cancers, they're higher in regions with higher prevalence of smoking rates. And although environmental carcinogens can be responsible for some cancer cases, most cases appear to be related to lifestyle and behavioral factors such as smoking. And so I'm going to put a slide here up on the screen. We have um, 3 maps available in our report. The one that I chose to show for folks today is a look at the state where we've highlighted counties in blue that have greater than the Wisconsin overall rate for both incidence and mortality. And we do know that lung cancer rates tend to be higher in rural areas than in urban areas across the US. Again, the reasons for these geographic disparities are very, very complex and overlapping. But many counties tend to have higher lung cancer incidence and mortality because of some of the top reasons are later stage diagnoses related to low screening rates, meaning cancers can be found they're found at a later, more advanced stage when treatment is less effective. Rural areas in particular have fewer low-dose CT scan facilities for screening and early detection. And I know later today we're going to hear from Megan at Advocate Aurora about some of the efforts they're taking to increase lung cancer screening for high-risk individuals. We also know that in certain rural and low-income communities, they tend to have higher smoking rates, which is the biggest factor for lung cancer. They can also have higher exposure to environmental pollutants like radon, secondhand smoke, and other industrial pollutants. So later in the webinar, we're going to hear from Amanda at DHS from DHS's radon program about the work that they do to inform communities about radon exposure and what they can do to mitigate that. We know limited access to healthcare also plays a role. So many high incidence counties are in rural or low income areas where access to specialists and cancer treatment centers can be difficult. And then last and certainly not least, socioeconomic issues like poverty and lack of insurance, or communities where folks have a lot of difficulty taking time off from work, making it harder for them to get screening and timely care. So yeah, I can't wait to see how this presentation kind of ties all of these access issues together. I also wanted to point out that our report does have county level lung cancer data available. We stuck it all the way in Appendix 6. So it's visualized in maps, but if you work for a local health department or you work in a particular community or jurisdiction, we do have county level data available for both incidence and mortality. So you can look at total cases, total deaths for the last 5 years of available data. We also have the rates, and there are a few online public platforms that we make available for free, and I can drop some links in the chat once I stop sharing my screen. If you haven't had a chance to check those out, you can pull down lung cancer data for your community or for the entire state of Wisconsin that the Wisconsin Cancer Reporting System makes available. So we also have a screening section in the report, and just one of the big takeaways is that early detection through screening is a really critical component in the fight against lung cancer. We do know that despite a lot of the benefits, screening rates have remained fairly low for high-risk individuals. So the U.S. Preventive Services Task Force recommends an annual screening for lung cancer with low-dose CT in adults aged 50 to 80 who have a 20-pack year smoking history, I believe. Or those who have currently quit within the past 15 years. I'm sure Megan and others who are going to talk about that later can correct if I said anything wrong there, but screening for high-risk individuals. So in 2022, about 19% of adults at high risk were screened for lung cancer. that is slightly higher than the national average of 16%. So all the folks that are working on that making Wisconsin look pretty good. Finally, some of the key data takeaways from our report. Lung cancer incidence and mortality in Wisconsin declined significantly in the last decade. We did note that lung cancer incidence is declining at a slightly slower pace in Wisconsin compared to the US overall in recent years. That was that little difference we were seeing in 2018 forward. Like in the US, Wisconsin men also have higher rates of lung cancer than women in general, but particularly at ages 60 plus when lung cancer is more often diagnosed. Again, non-Hispanic American Indian Alaska Native populations had the highest rate of lung cancer in Wisconsin from 2017 to 2021 combined. And non-Hispanic Black populations had the second highest incidence rate. The racial and ethnic disparity between non-Hispanic American Indian, Alaska Native, and Black populations compared to white populations in Wisconsin, we did note that disparity is notably larger in Wisconsin than it is compared to Wisconsin overall. And then finally, lung cancer screening can find cancer in early stage where there are more treatment options. And although screening rates remain a little bit low, those who are at high risk may benefit from interventions to raise awareness of screening options. And if you have any other questions about the information in the lung cancer report, I believe this is listed in the report itself too, but there's the info at wicancer.org where you can contact the collaborative and we'll work to answer any questions you've got. So just want to say thanks for your time and yeah, we'll have questions after presenters are done. So I will stop sharing and hand it back over.
Thank you so much, Lena. I appreciate it. And so we'll switch over now to Megan.
Had to find that unmute button. Hopefully everyone can see my screen.
Looks good.
Awesome. All right. So thank you. Hello, and thank you for having me. My name is Megan. I manage the lung screening program at Advocate Aurora Healthcare. So for those unfamiliar, now known as Advocate Health or in the Midwest region, Legacy Advocate locations are in the Chicagoland area, and Aurora locations are on the eastern side of Wisconsin. I've been an oncology nurse for the past 11 years. I've gone from inpatient to outpatient to thoracic navigation. So I've seen kind of the continuum, and now I'm here on the screening end of things. I'm excited to see and hear all that the Wisconsin Cancer Collaborative has done for lung cancer in the state, and excited to highlight our program and what we're trying to do to attack improving those lung screening rates and lung cancer mortality. All right, so a little background on our program. In 2014 through 2016 in Wisconsin, we had 9 decentralized lung screening sites. These were managed by a representative from each facility. Typically, it was a nurse navigator, and they were managing that patient load however they could, usually in a dual role. Also supporting the ACR registry since 2016. And this was really without any kind of standardized process. Again, doing those dual roles, typically whenever they could take care of the screenings, they were doing that. And that's what I was doing as a navigator at one point. And then in 2017, with a lot of the guidelines being developed and changed and insurance becoming more readily accessible to lung screening, the best practice alert was created in our electronic health record. We use Epic. So that was a flag that, if you're not familiar with best practice alerts, or BPAs as sometimes they're known, alerts to the provider as they're seeing their patients typically at an annual visit to alert them that their patient is eligible or is in need of some kind of health maintenance task. So then in the fall of 2018, we formed a dedicated team in Wisconsin. This was created to really centralize the management, standardize the processes, It started with 2 coordinators, a data specialist and a data analyst, created a framework, again, to track patients appropriately and have some meaningful data. We now track patients using that model consistently for their annual and their baseline screenings, also short-term follow-ups, incidental findings that align with the ACR registry, and then, of course, staging that aligns with our cancer registry. And then the messaging to the patients as well as their ordering provider. About that same time, Advocate and Aurora merged together. And then later in 2022, in the fall of 2022, the Illinois program was much like the Wisconsin program in 2014, 2016 under a decentralized model. So we combined those 2 programs to create one large centralized program with a hybrid model. So centralized management and tracking of the patients with the referring providers being typically their primary care pulmonologists or thoracic surgeons that they were seeing at the time. We combined to one lung cancer screening registry. We standardized workflows and that policy. We did a ton of staff education on the program, the support that they now had through our program. And then 2 additional dedicated thoracic tumor conferences were created. So that would be 4 total, 2 in Wisconsin, 2 in Illinois, that we're able to discuss our suspicious cases at. It's kind of the who, what, and where we are. Some of it I already kind of went over, but where we are now, current state, is that we have 7 nurse coordinators. We have 5 data specialists. We have 1 manager, myself, but I also undertake a small coordinator role. And then we have physician champions and a number of our multidisciplinary teams. So pulmonary, thoracic, radiology, and oncology are kind of that core. And we have physician champions that support our work and are advocates and passionate about lung screening and lung cancer care. In 2024, we served near 26,000 patients, so 26,000 screenings. We're very excited about that volume growth, and I'll talk a little bit more about that later. As I mentioned, we're a hybrid model, so our orders are placed by the providers seeing the patients with centralized management by our team. We look at the USPSTF guidelines, but we also follow the CMS criteria. That's the majority of our payers. And so our criteria is typically up to age 77, despite USPSTF going up to age 80, knowing that some patients may be eligible beyond that age. We also support the smoking cessation work, tobacco documentation within our healthcare system. We're often looked to as the resource or subject matter experts within that space. We had historically provided smoking cessation programs for our patients, now working towards an e-referral and making that documentation much smoother. Again, patient education at its core. We have 50 locations across Wisconsin and Illinois, again, in the eastern part of Wisconsin through the Chicago and Chicagoland area. Our locations include hospitals, so inpatient hospital settings, as well as outpatient imaging centers. We found during COVID that a lot of patients really wanted to move towards those outpatient imaging centers. So we've placed the focus on opening those locations during that time and really has really helped provide a well-rounded access to our patients. Do lots of community education and awareness events. I'll get into that a little bit more. But then again, at our core, our main referrers are primary care offices. So partnering with them throughout the continuum of a patient's journey through their lung cancer process really helps us be successful. So how are we doing this? I mentioned our health maintenance topic or our best practice advisory. So at the time the patient is seeing their provider, they have these various alerts and care gaps that their provider needs to address, lung screening just being a number of them. Our electronic health record defines a patient eligible for lung screening based on what's documented in the chart for their tobacco history, as well as their age. Tobacco documentation has been something that we've been starting to really want to look at and improve. And we, as you can see there on the right-hand side of your screen, we did an audit recently of a small sample size, but found that 61% of that audit didn't have complete documentation. And so that's a potential big number of patients that might be eligible for lung screening that aren't getting those flags to their providers saying, hey, this needs to be discussed at their visit. So that's something that we're evaluating now and hope to improve throughout the year. Also on the right side of the screen is part of an order set. So I mentioned the care gaps or the health maintenance topics that are in our EPIC charts. And so as they're going through this will be something that they can click into as it identifies the patient being eligible. So it provides that ordering clinician with the order as well as the correct diagnosis codes. We know that these two diagnosis codes that you see here are mainly what CMS and other carriers want to see as they're getting these order placed. So we try to make it as easy as possible to get these orders in for their patient. We have unique orders for screening. So it's the same order for our baseline or annual, but we also have a dedicated order for their follow-up exam. This helps to make sure that we are able to track these patients, as well as making sure that the appropriate lung RADS assignment gets to that screening or that follow-up rather than another guideline such as Fleischner's. I mentioned the various quality metrics and evaluation that we do of our program. It's paramount for our success to make sure that we are constantly improving and evolving with the documentation and state information that's coming out. Not so long ago, the American Academy of Family Practice did not support the USPSTF recommendations. So use of data and quality through the Nelson trial and through our homegrown data gives that reassurance to our providers that it is the right thing to do. And of course, now it is recommended, but I think there's always data to help solidify why we should do what we are recommending. So an example of that is the concern over performing unnecessary invasive procedures to patients, given the high false positive rate within screening. So we looked at bronchoscopy complication rates following a lung screening, which we found to be very, very low, near almost insignificant. And so to provide that back to our primary care providers, really allows them to have that discussion with their patients, that it is a safe procedure, regardless of what that result looks like. Of course, we're also looking at our screening rate and adherence to that annual screening. And as I mentioned, tobacco documentation. Tobacco documentation, as I understand, is a national concern, not unique to our facilities. So how can we make that better, not only for our facility, but beyond that, and working with EPIC or other institutions to make that better. And then I mentioned staff and community outreach. So we do lots of lobby tables, especially in the month of November. The team is very involved in being on site, usually at our facilities or on our campuses, but we also get out into the community at our various festivals. Being in Milwaukee with the Summerfest Fairgrounds, there's constantly festivals to be a part of. So that's a great thing that we try to take advantage of. And then recently we've gotten into more sporting events. We've tried to get a little creative by partnering with the Chicago Bears and the Packers tailgating and trying to be in places where lung screening and healthcare is not typically seen at tailgates. So, but people are welcoming and open to that. So it's been a positive experience so far. So how we've built success, again, aligning workflows has really standardized that approach to management and tracking. So making sure that patients aren't falling through the cracks, and then improving that provider and patient experience. So aligning that workflow helps their clinicians provide good informed decision-making with their patients, especially as at that first time they're going through that screening. They know what to expect from start to finish, not only from the scan itself, but also how the patient is taken care of on the back end and maybe on the not so obviously seen end through our program. It also ensures that our data is accurate and reliable. We want to make sure that the data that we put forth to the community or to our executive leaders are thorough and detailed and accurate. I mentioned our community and staff education awareness and partnership. We partner with various key stakeholders, and that's going to be key beyond the multidisciplinary team that manages the clinical side of things. We work with the site leaders, business development, marketing, BI developers, IT, the executive leaders, and then the local and national networks and organizations like this. We want to partner as much as we can because lung screening is something so underutilized that, to be selfish in our own facilities, doesn't do the service to the patient or the community. So we like to partner. And then I'll go into a little bit of data that we've been able to accumulate over the years, and what we can show. We did a project recently, a report. We developed a report looking at our top referring providers for each area, and then each coordinator that supports that area sent a thanks or a kudos to them. And it's been really well received to just acknowledge, hey, you're doing a great job for your patients. Lots of appreciation, general appreciation, and thanks for reminding them and letting them know that they're doing a good job. But also we've been invited to share our program and various education at their local meetings. So it's just been a great outreach project. So getting into some of the data that we've put together, stage shift is always going to be top of mind when we're talking about lung cancer and lung cancer screening. Through this data, what you see in that graph is cancers diagnosed from a lung screening since 2017. So as a reminder, the program was developed in 2018 and then again aligned in 2022. So as you can see, in 2017 through 2019, a very steady incline in early stage, very steady decline in late stage. Then COVID happened and that got shaken up a little bit through 2020 and 2021. And then in 2022, we started seeing those improvements start to take place again as patients started to come back for those annual screenings and capturing those early stage diagnoses. Again, in 2022, we aligned with our Illinois market. And so we did see a little decline at that time as we were developing those workflows, processes, and standardizations. And as you can see, so 2024, this was through Q2 of 2024, so not even complete data for that year. We had 160 cancers diagnosed, and 76% of that were early stage. So we're really proud of that, really excited to see how 2024 rounded out. But I think it really shows that a structured, centralized program, both as you can see from 2017 to 2019 and then 2022 to 2024, that stage shift is impacted as a result of some standardized tracking and management. So this is just a little bit of a different graph of that. So looking at all of our lung cancers that were diagnosed from 2016 to 2023, those that were screened for lung cancer compared to those not screened for lung cancer are the two graphs that you see. So those that had a screening, 66% of them had an early stage, and almost inversely, those that did not have a lung cancer screening, only 38% had an early stage diagnosis. So it just really solidifies that screening really does detect early stage lung cancers and is really important to be done for the appropriate patient. And then this is just our volume growth over the years for our annual and baseline lung screenings. As you can see, that volume has grown over the years. We're at almost a 24% screening rate, so a little better than the state average between all of our programs in Illinois and Wisconsin. But we know that we still have a long way to go to be capturing all of the patients that are potentially eligible. We're hoping to do that by identifying patients through better assessment, so better question asking for their tobacco use, and then likewise that documentation on the other end. So this was a research study that we recently did, kind of looking at non-lung cancers. But what are we looking at in terms of the extrapulmonary masses that are seen incidentally on a lung screening? So I worked with our radiologist team to gather this data. Our data team worked together to look at all of the incidental findings that we had seen over the past several years since 2016. And of those masses, 1,224 patients had that S modifier for an extrapulmonary mass. 72 of these were found to be malignant. So specifically looking at the renal cancers. So 24 renal cancers were diagnosed out of that patient list. That was about 33% of that. Of those, 79% were stage 1 cancers. And for a 5-year survival, 91% were still alive and doing well, and only one was deceased at that time. And ironically, it was related to a diagnosis of lung cancer. So it's been great to see that that we're not only making an indent in the staging of lung cancer, but also for the incidental findings that are seen on a CT scan. I think nationally, about 76% of patients with renal cancers have a 5-year survival. So to be at 91%, we're well above that average. And then in addition, through the use of lung screening and incidental findings, renal, hematologic, and pancreatic malignancies were identified at an earlier stage and had better overall survival related as compared to the general population. So not only renal, but hematologic and pancreatic were all their more notable incidental finding malignant masses. So we definitely still have our challenges. We definitely feel that community education and staff awareness is still a big component of making, developing our success, continuing that growth, improving our screening rate through the various ways that I've already mentioned. We look forward to partnering more with our marketing and media teams to try to capture those audiences. For staff, we worked on attending monthly meetings, providing resources and education to what our program can offer. We also updated a learning module that our staff can take. It's about a 30-minute process that goes through what is lung screening all the way through tobacco documentation. And then we have a hotline phone number for both patients and our staff to contact if they have questions, concerns. And that's not unique to just our patient population, but the community as well. Of course, we want to increase access and availability. While we have 50 locations across that eastern side of Wisconsin and Chicagoland, we feel that there's more opportunity, perhaps a mobile screening unit, or opening more sites in those areas that are underserved. We're always looking for opportunities to do that. And then again, smoking cessation tools and documentation, which I've talked about a couple of times now. Really important that we do a better job as a nation, really, to document that better so that we can capture the right data. And so what's next for our program? We're excited to move forward with a lung screening management software. Currently, we're using Excel spreadsheets. And as you can imagine, 26,000 patients on Excel spreadsheets is a challenge. So we are looking forward to those improved efficiencies. We are excited to use the various analytics and reports to help our growth and outreach and really understand the people that we're serving. We are working towards utilizing the smoking cessation e-referral. So really meeting patients where they're at and when they're ready to quit smoking and not waiting on that. Again, smoking documentation, we're going to audit that. We're going to study that. We're going to get the right people involved to help improve it. And then continually reassess that. And then again, community engagement. We continue to partner with our community in the various events that we have done, and then looking forward to more creative approaches in the future. And thank you. That's all I've got. I have my information listed there in our hotline number if you would like to refer any patients or have any questions for me. Thank you.
Thank you so much, Megan. You got a lot of kudos in the chat and a lot of questions. And so we'll come back to those of God and will. But for now, we're going to switch over to Amanda and the Radon program.
All right, just getting set up here. All right, how does that all look?
Looks great.
Wonderful. Well, hi, everyone. Thank you for having me today. As mentioned, my name is Amanda. I am the newer Radon Program Manager with the Wisconsin Department of Health Services. That is your state public health department. I started in this role in just about last May. And even though I'm newer to the topic of radon, I am not new to environmental public health hazards. I've been working on various different environmental health concerns as I've been working in the Bureau of Environmental and Occupational Health for almost 9 years now. So I'm just really excited to be working on this topic. It's a really good one. So today I'll be again talking to you a little bit about radon, our radon program, and the state of radon issues here in Wisconsin. Now, first, I just wanted to start off by wishing everyone a happy National Radon Action Month. This January, the Wisconsin DHS is joining the EPA, CDC, and state and local health departments across the U.S. to raise awareness of radon and encourage folks to test. So the opportunity to present for this webinar really could not have come at a better time. All right, now I'd like to make sure that we're all on the same page when we talk about radon. So let's start with just some very basic definitions. What is radon? It is a colorless, odorless, radioactive gas that comes from the natural radioactive decay of uranium and radium in rocks and soil. It is indeed our largest source of background radiation exposure. It is an environmental health hazard when two things happen. A, radon gas enters homes through cracks in their foundations and builds up to high levels in the indoor air. And B, when occupants are exposed to high radon over long periods of time. We're talking years and usually many. It is a leading cause of lung cancer. It's the second overall leading cause of lung cancer and the leading cause of lung cancer, specifically among non-smokers. According to the EPA, radon exposure is responsible for approximately 21,000 lung cancer deaths in the United States annually. And some newer research out of the Indoor Environments Association estimates that 962 Wisconsinites have radon-induced lung cancer. So you can't see it, you can't smell it, and so therefore it just must not be there, right? Well, of course not. And so we're here today to talk to you about, again, what our program does to ensure folks are aware of this invisible hazard. So let's talk about the structure of our radon program here at the Wisconsin DHS. In 1988, the U.S. Environmental Protection Agency established the State Indoor Radon Grants Program, which was created in response to growing concerns about the health risks of radon gas. The Wisconsin DHS was an early recipient of this grant, and to my knowledge, we've received it every year since. The grant has a 40% match requirement, which we're able to match with general purpose revenue funds. The match requirement helps ensure sustainability of the program long-term. Our state program has 2 full-time staff. That is myself as the program manager and Kim as our outreach specialist. Together, we run a long-standing program that seeks to provide expert-level radon health education and outreach to Wisconsin citizens, to encourage radon testing among homeowners, property owners, and schools, and to collect and document data demonstrating radon risk across our state. Now, what is unique about our program compared to other state programs is that we shuttle a good chunk of our grant money directly to the local level. We subcontract with 17 local health departments that serve as regional radon information centers. These RICs, as we lovingly call them, have professionally trained radon staff that provide radon leadership and support for counties within their region. They also lead county and region-wide outreach activities, ensuring that radon education and test kits get into the hands of citizens in every corner of our state. Testing for radon is incredibly easy. Anyone can do it, and it's inexpensive. Kits are usually around $25, including laboratory analysis. And right now, during National Radon Action Month, many of our RICs have been hosting test kit giveaways or offering them for steep discounts. Just last year alone, RICS distributed 7,209 short-term kits, of which 5,580 were returned. That is an incredible 77.4% return rate, more than any other state in our region. This model clearly works very well in Wisconsin because RICS are effective at reaching their communities with targeted radon health education and test kits. They know what they need to do to successfully reach their populations. All right, so let's continue with the successes. Our biggest success story in recent years has undoubtedly been the enactment of a new Department of Children and Families rule affecting licensed child care centers. As of March 1st, 2023, it is now required for all licensed child care centers to test for radon in the lowest level used by children, at least 7 hours per week, and to mitigate when levels meet or exceed the EPA's action level of 4 picocuries per liter. Our DHS radon program was a crucial partner for the DCF during their planning and rollout of this new rule. And this new rule has had a significant impact on protecting the health of our kiddos. Since it went into effect, 41 child care centers across Wisconsin have mitigated high radon, protecting over 820 children enrolled in care. Our state health officer agrees that preventing exposure to high radon in places where kids spend a lot of time is a significant way to reduce their overall exposure to radon. Okay, so now let's talk about some of the challenges that we face. Overall, there really are just a few state laws that protect Wisconsinites from radon. Our state requires a radon public education program. That's us, and we're certainly thankful for that. Sellers must disclose known radon levels in the sale of homes. While that's great, testing is not required. And finally, there's the new DCF rule, which protects children enrolled in childcare. However, unlike our neighbors, Minnesota and Illinois, schools are not required to test for or mitigate radon in Wisconsin. This means that although we are protecting young kids enrolled in childcare, frankly, we're failing to protect them through the remainder of their developing years. As schools are likely to be the second largest contributor to a child's radon exposure after their home, it's really important that schools also test. Without a school testing requirement in place, we encourage schools to voluntarily test at least once every 5 years and after any major renovations. Additionally, renters do not have any special protections when it comes to radon. That is a stark contrast to our next door neighbor, Illinois, that not only requires tenant disclosure by the landlord for radon, but that also allows tenants to lawfully break their lease if they have high radon and their landlord won't mitigate. In Minnesota and Illinois, state building code requires radon-resistant new construction in all new build homes. There are no such code requirements in Wisconsin. And finally, Wisconsin does not require radon service providers, including measurement and mitigation professionals, to be licensed or certified. There is no state board that exists to oversee licenses or certifications of people performing this work. And of course, there are risks associated with uncredentialed radon service providers. Radon measurement contractors, including some home inspectors who offer radon testing services, might opt to use less accurate or poor performing radon measurement devices. If that happens and radon readings are misrepresented to a home or property owner, there are no civil or criminal penalties imposed. There are ANSI accredited national standards available for both radon measurement and mitigation practices. Those standards are largely based on research and evidence-based best practices. Radon mitigation installers who do not follow these practices may install systems that not only are ineffective, but may inadvertently cause harm to building occupants. Pictured to the right here is an example of an improper mitigation system installation. The fan, which is the bulbous part there in the middle of the tubing, is not only installed on an angle, which can cause condensation problems, but is also installed in a basement, which presents a safety issue because radon could leak back into the house and potentially at greater rates if the fan becomes compromised. And finally, licensed childcare centers could be affected by both poor radon measurement and mitigation practices. Now, while it's true that homes, schools, and really any other buildings could also be affected by this, it's important to note that we don't yet have regulations for those spaces. These issues could very well defeat the purpose of having a policy in place to protect children enrolled in care if, for example, mitigation is required, but that mitigation is ineffective due to a poor installation job. So as you can see, while progress has been made here in Wisconsin, there are plentiful opportunities, particularly in the policy sphere, to further protect our citizens from harmful radon exposure. Now, at the beginning of our talk today, I mentioned that it was National Radon Action Month. This is hands down the busiest time of year for our program. We run a statewide campaign to raise awareness of radon risks and encourage folks to test. So far this January, we have partnered with the Wisconsin Broadcasters Association to put out statewide radio ads. We've worked with our governor's office and had Governor Evers issue an official proclamation recognizing National Radon Action Month. We've put out statewide digital ads in both English and Spanish, and we've rolled out a bunch of social media posts on our various DHS social media platforms. We also work closely with our 17 radon information centers to ensure that they are equipped to lead local campaigns in their regions. Now, of course, all of this tends to get a lot of media attention, and I've had the fun, albeit maybe a tad stressful at times, opportunity to respond to media inquiries about radon. So far this month, I've been interviewed by WPR, WRN, WISN Milwaukee News, and Me Wisconsin Latino News. To my knowledge, this was the first time in the history of our program that we were asked to interview in Spanish. Thankfully, I had assistance from a bilingual colleague to successfully deliver this interview live. It was certainly another big win for our program to be able to reach Spanish speakers in Wisconsin with radon information. And we continue to identify ways to do that. Now, looking forward to the rest of 2025, we have a lot of exciting projects and activities on our plate. The most important one that I'd like to share today is our preparation for the 2025 Wisconsin Radon Conference. This is a day-long learning and networking experience that we host about every 2 years that draws radon professionals from both the private and public sectors, as well as anyone interested in learning more about radon. Right now, we are in the early stages of planning and attempting to select a date and venue, but we expect the event to take place late this year, likely in November or early December. Attendance is open to WCC members, and members are encouraged to attend. We'll be sure to send save the dates and invites through the WCC listserv, so make sure you keep an eye out for that. Again, thank you for having me. I think we'll have a Q&A at the end, so both myself and my outreach specialist, Kim, are happy to answer any questions. There is our contact information on the screen. You can contact us directly through our program email address or phone number, and you can find a bunch of information about radon, including where your nearest radon information center is for that free or discounted kit at lowradon.org.
Thank you so much, Amanda. That was some wonderful information. Totally agree. We definitely should be talking about radon more. So thank you, thank you. So yeah, now I think we can switch over to doing some questions. So I collected some questions in the chat. So the first one is for Megan. So identifying eligible patients sounds like no small task. What year did you establish a baseline screening rate, and have you been able to demonstrate increases year after year?
Yeah, so this is a little bit of a nuanced answer, but as we may have seen, or certainly I saw with American Lung Association, and the screening rates kind of changed their how they're calculating that screening rate this past year. So historically, it was like in the 4, 5, 6% range, and now it's in 19 and teens and 20s. And so I looked into that a little bit more, and they had used the behavioral risk factor surveillance system to better calculate that. As I continue to mention, the tobacco documentation is such a challenge, and so historically we were using the data that we had, and so the data out is only as good as the data in. And so our screening rate using that algorithm was also in that 3, 4, or 5% range, in a kind of in alignment with what American Lung Association was able to do. And so since then, we've also kind of adapted a little bit in the same way that American Lung has as well, using that different data set. And maybe there's someone on this call that has a better, more finessed way to describe that. So we also use that. So the CDC data and looking at our population of who are identified as tobacco users, and then looking at our numerator, so the screenings that we performed that year. So in short, yes, we have seen an improvement as our volumes have naturally gone up. Is it a perfect science or a perfect rate? Probably not. But again, that data out is only as good as our data in.
Great,
I think there
you.
was a question about the denominator. That kind of ties in. I guess I'll just answer that. Our denominator is about 108,000 patients. So with our nearly 26,000 screened patients, that gives us that rough estimate of 24%.
Great, thank you. And then we also got a question. Are you also asking about hookah or vape usage?
Yeah, so they're not included in our screening rate because it's not part of, at least currently, part of the screening criteria. We do have documentation spaces for e-cigarettes or non-cigarette tobacco use within our EHR. So it's certainly important information, very valuable when we are looking at our smoking cessation resources and knowing what our audiences are using. But in terms of lung screening, the lung screening program isn't looking at that as closely as our tobacco cigarette users.
All right, and then the next question is kind of a combination of Megan and then also Amanda and Kim. So a comment that I wonder if you think there are, well, first, this is such great work, and I agree. I wonder if you think there are opportunities to add radon screening conversations for those patients who are active smokers. And this person said they'd be interested in partnering on this with you all. So if either, Megan or Amanda or Kim, you want to speak to that potential opportunity there.
Well, in my opinion, I think, yes, it's the second leading cancer, cause behind the tobacco use. So absolutely, I think there's opportunities. Is it currently part of screening criteria to get someone screened if they have a radon rate in their home? No. But are there opportunities to maybe educate our patients coming in for screening about the risks of radon in their homes, and kind of adding to their risk factors? I think absolutely.
And I can also just add that what's really challenging is that radon exposure is not a criterion for an eligible criterion for people seeking lung cancer screenings. And so that's really, really challenging. If you go to savedbythescan.org, and that's meant for folks to kind of fill out whether they're eligible for, whether they really should think about a lung cancer screening and whether they're eligible. There is no mention at all about radon. That is something that I've actually reached out even personally, about, but that's challenging. So I think absolutely any kind of conversations that clinicians can have with patients around radon, even if it's just a simple, hey, have you thought about radon, about testing your home for radon? I mean, it could be very, very effective.
Absolutely. And that's awesome that they're already close for kind of partnership in the chat. That's what we love to see. So then this question is also for Megan. And there other folks have commented as well, but if you have any other thoughts, do Medicare Advantage plans consistently pay for lung screening? And do you have any challenges with insurance not covering lung screening for patients 50 to 64?
Yeah, so I saw Lori commented on this. She's one of our coordinators, so definitely echo what she has already responded. But yeah, we have some issues with approval of screenings, regardless of what their insurance carrier is. But a lot of times, as you mentioned, it has to do with the diagnosis code that was used. What we see a lot is patients are coming in for their annual visit and they are getting orders for a number of things. And then those diagnosis codes for those orders accidentally get tagged on. And suddenly someone getting their PSA with risk for prostate cancer is getting a lung screening. So it just adds to that confusion a little bit. So diagnosis codes, making sure that the right ones are used is really important. And then the other kind of thing that we don't always understand is that sometimes, especially with Medicare, we may see our authorization specialist saying no prior authorization required. Well, that doesn't always necessarily mean that that person has coverage. And so it's really important to understand those differences and those nuances. A little bit of a foreign language from even me, but sometimes making sure that we understand the coverage versus authorization is two different things. But generally, we have more issues with our follow-up testing not getting approved under different insurance types, particularly those on private insurances. We have a process and work alongside our providers to help them with appeals as needed or peer-to-peer, making sure they have the resources to advocate for their patient if needed. So we do see that from time to time, not often, but from time to time.
Great, thank you. And then another comment from David. So this is sort of a general question if any of the folks on the call have thoughts. So the last question is whether the state has looked at PFAS in the state with lung cancer rates and does anything align?
So that's a good question. PFAS is really a beast because there are thousands of those types of chemicals, and they're all different sizes. They have different. Some of them have slightly different chemical properties, and frankly, that means that they can cause different effects in the human body after exposure to high levels over long periods of time. And so what we do know is that, generally most PFAS can, cause a specific list of health effects. And lung cancer is not in that list. It doesn't mean that it can't. I just think that the research is just not quite there yet, or that we're not seeing that come up as one of the major causes of lung cancer.
This is Lena too. From the Wisconsin Cancer Reporting System side, I'll just add that, at a national level, I know that some Wisconsin cancer incidence data essentially get submitted every year to the CDC and to now we're partnering with some folks at NCI as well. So our incidence data are made available for researchers who are interested in investigating more emerging exposures and questions like this. One that I'm thinking of off the top of my head is there was a large prostate, lung, colorectal, and ovarian cancer screening trial. I think maybe NCI had funded that a few years back. I know our data were used in that, and there are some researchers using that information for more nested trials as well. So I would absolutely agree with Amanda that the science is still very new and not there, but just want to reassure people that we are providing researchers, qualified researchers who are asking these questions with national data sets with the information that we have on Wisconsin cancer residents. So
Thank you for your thoughts on that. And then passing it back to Amanda or Kim, are there any advocacy efforts addressing some of the radon policies that neighboring states have for here in Wisconsin?
There are. I am aware of mainly maybe one that is more related to the the credentialing issue of radon service providers. So there is interest, genuine interest in that, especially really among the private sector, because folks are seeing incorrectly installed mitigation systems in the field in their work. So there is movement, I think, there. Unfortunately, at least to my knowledge, I'm not aware of any other efforts.
Thank you. And then some helpful links in the chat if you're interested in learning more about the low-dose CT lung cancer screening test, and then also the USPSTF lung cancer screening recommendations. And then we also have a comment, are there statistics for radon as a cause for cancer by county in the report? And if not, where can I find that information?
No, if I can take that one. At least in the Wisconsin Cancer Collaborative published lung cancer report, if that's what's being referenced, we don't have statistics specific for radon as a cause of cancer. We're just presenting all primary lung cancer incidence cases. There's mortality data as well in there. So that's a very complex question. I will say that if you want to have a follow-up conversation about if you need more detailed lung cancer, bronchus cancer incidence information for specific counties, you can reach out to me if you can't find it either in the report or on some of the online portals that we make our data available. So happy to chat more about that.
Great. And then, so Amanda or Kim, do you provide lists of credible/qualified radon mitigation companies in the state of Wisconsin?
We certainly do. So again, even though radon service providers are not required to be licensed or certified in the state of Wisconsin, that doesn't mean that there are many, many, many folks who actually do seek national certification. So our recommendation to folks, anyone who's looking to have professional radon measurement or mitigation services, is to go to our website, lowradon.org. And there we actually link to the two EPA recognized third-party credentialing organizations that certify radon professionals. That is the National Radon Proficiency Program, the NRPP. I would say the vast majority of folks in Wisconsin just happen to be certified with that organization. And the other one is the National Radon Safety Board. So, and what's really nice, those websites, they're very user-friendly. You can go directly to them. There's a find a professional search function. You just type in your zip code and it'll give you a list of all the closest certified providers nearest to you.
That's an awesome resource. Thank you. And I see Kim dropped some helpful links in the chat too. And then we have another question for the radon folks. Even though it's not required, do you know if most schools do test for radon voluntarily?
That's a great question. And I'll be completely honest, we actually do not have great information on that. There was I'm aware of a study that our program led maybe a few years ago that tried to obtain that information. Unfortunately, the response rate was just extremely low among schools. So I unfortunately, actually, off the top of my head, I can't remember that percentage of how many schools that did respond said that they did test, maybe 30 or 40%, something around there. But again, those are of the folks that actually responded, of which there were it was maybe about 50% or less. So it's unfortunately we just don't actually have good information on that.
Thank you. Any other questions for any of our presenters today? Oh yeah, okay. Megan, is there an opportunity to partner with local health departments in providing small group community education on screening?
Yeah, absolutely. Yeah, I mean, as my personal program or just in general, but absolutely. I mean, that's how we work together to make this better, improve our screening rates, improve lung cancer mortality. I think finding what those issues are within your community is going to be really important. And maybe that looks like a community needs assessment, or maybe that looks like using the data that we discussed today. Maybe you're in those rural northern parts of Wisconsin and there's a huge disparity there. I think really evaluating what your community needs is just really important because not every community is the same. Not every community needs the same thing. And not every community has the same resources. So we're very fortunate that a lot of our locations are in very urban or suburban areas with a lot of resources. We know that we're lucky in that, and not everyone has that opportunity. So figuring out what those needs are and what resources you can provide is really important. Stephanie, if you are looking to partner with us, I am happy to talk further about that. For example, one small but big thing, we partnered with Black and African American community who provides resources to our community. I live in Green Bay here, and our pulmonologist got involved to support smoking cessation efforts. And so tied into that naturally was lung screening and promoting and bringing awareness and education around that. They did I think it ended up being an 8-course session, and it was like a sit-down support group to talk about the benefits, risks, and solutions. And, it was really impactful. So that was a need that we saw and able to provide a free resource to that and connection on how to take next steps.
Awesome. Thank you. Like I said, just really love seeing all this kind of connection and partnership in the chat. That's really great to see. That's why we have calls like this. So I'm really excited. So we now, just with a couple of minutes left, want to kind of open it up for discussion for everyone as well. And one question that we wanted to ask was, as far as for all of you on the call, your role and your organization, what would you consider to be the biggest lung cancer priorities for you and your role in your organization? So if you want to pop those in the chat or come off mute. Lung screening. Tobacco cessation and survivorship and promoting screening. Absolutely. Understanding who is eligible seems incredibly challenging for all. Absolutely. Promoting screening, radon test kits, tobacco cessation. Yeah, definitely. Access to screening, can't really do it in mass screening events. We've seen, I think everyone brought up throughout their presentations, access being an issue or being a challenge for different communities. Great. Okay, so now, yes, awareness, smoking cessation, accurate documentation of smoking history, providing incidence and mortality data for Wisconsin to track progress on public health and clinical improvements. Yes, only as good as our data. Increasing research on the long-term impact of hookah and vaping, partnering with health orgs to bring info and resources to our Southeast Asian communities. Absolutely. Yeah, it's really awesome to see. Oh, perfect. Another. We still have a long way to go with screening, promote, and educate eligible patients that screening is so easy. Definitely. Yeah, it's awesome to see kind of different representations of where folks work in the cancer spectrum and kind of the framing that they take for this work. So thank you all for your thoughts. And now I'm just going to share the last couple slides here. So we have, as part of our Wisconsin Cancer Collaborative, every year we put together the Wisconsin Cancer Summit. And so we're really excited to share our save the date. So it'll be hosted this year, September 24th and 25th in the Wisconsin Dells at the Glacier Canyon Conference Center. And our organization will be celebrating and reflecting on 20 years of cancer prevention and control work. So we're really excited about that, and we'll be sending out more information and registration information soon. We're also excited, especially for the folks on the call in the northern regions of the state, that we're in the process of confirming dates in early and mid-May for our 2025 regional meetings in Hayward and Green Bay. So we hope to see you out there. And again, we'll send more information about registration and confirmed dates through our newsletter. And then we also want to say, just in closing, as we've heard today, lung cancer is a really complex cancer topic. While it's screenable, it also leads the state in cancer deaths. And to address these community-wide challenges, we need an interdisciplinary approach. And that's why we would love to have any of you on the call that are not already part of the Wisconsin Cancer Collaborative to join us. So regardless of what part of the cancer spectrum you work on, or what region you serve, or what position you hold, we really need your expertise at the table. And joining the collaborative comes with access to resources, elevation of your organization's work, and also, networking opportunities like the summit and regional meetings. So you can find more information at this link or the QR code. And so kind of in closing, lung cancer isn't new, but we know that tobacco prevention messaging or screening guidelines or cessation techniques are constantly evolving. And so we've highlighted here a couple of WCC resources, and then also partners across the state that we have worked with that you can connect with to really learn more about and collaborate with in the lung cancer space. So again, super excited that you all joined us today. Thank you so much. Please reach out to us if you have any questions, and we are really grateful for your time today. Have a great rest of your day, everyone. Thank you.